So I want to start today with a bit of a visual exercise for you. Picture a stone arch. You've seen them.
Like an old Roman aqueduct.
Yeah, exactly. Or an old bridge. You've got the heavy pillars on the sides, the curved stones rising up to meet in the middle. But the entire thing, the structural integrity of that massive weight, relies on that one single wedge-shaped stone at the very top center.
Right, the keystone.
The keystone. If you pull that single stone out, the arch doesn't just get a little wobbly.
It collapses.
It turns into a pile of rubble in seconds. Now, in the Architecture of Disability Services here in Pennsylvania, there's a role that functions exactly like that stone. It's called supports coordination.
Which is a perfect analogy, really, because for individuals with intellectual disabilities or autism, the supports coordinator, or SC, they are the linchpin.
Right.
They usually aren't the ones providing the direct medical care or running the group home, but they hold the blueprint. They connect the medical, the social, the housing, the employment.
Everything.
Yeah. If that role fails, the complex structure of a person's life can crumble very quickly.
And that is exactly why we're doing a deep dive today. We are looking at a massive renovation of that keystone.
That's a big one.
We're analyzing a document titled The Performance-Based Contracting Supports Coordination Services Implementation Guide, which is a mouthful. It was published by the Pennsylvania Department of Human Services, specifically the Office of Developmental Programs, or ODP, back in July of 2025.
And before anyone tuning in hits pause because they heard performance-based contracting and assumed we're about to read a tax manual.
Stick with us.
Yeah, stick with us.
Okay.
Because this isn't just bureaucratic shuffling of line items.
It feels much more like a philosophical pivot.
It is. It's a fundamental shift from paying for quantity, how many 15-minute units did you log, to paying for quality.
Did the person's life actually improve?
Exactly. Did they find a job? Are they healthy? It's a move from accounting for time to accounting for lives.
So our mission today is to unpack this new system. According to the timeline in the guide, this goes fully live on January 1st, 2026.
Right around the corner.
Right. We need to understand why the old system was breaking, look at the 4 massive pillars of this new plan, and then get into the weeds of the money and the timeline so you understand how this actually affects people on the ground.
It's a heavy lift.
Yeah.
But to understand where we're going, we have to look at the baseline. We need to know what we're actually fixing here.
Okay, so let's start with the role itself. We use the arch analogy, but practically speaking, what is a supports coordinator doing on a Tuesday morning?
The guide defines them as establishing an alliance with individuals and families. And that word matters. Alliance.
They aren't just gatekeepers stamping forms.
No, not at all. They're locators, coordinators, monitors. They are the bridge to housing and employment and health goals. They're the ones asking, what do you want your life to look like? And then trying to find the pieces to build it.
The text mentions the concept of realizing an everyday life. That sounds like a specific term of art in this field, not just a casual phrase.
It is the core philosophy of the ODP. Everyday lives. It's a value set of choice, control, health, safety.
Okay.
The historical context here is important. For decades, the old medical model treated people with disabilities as patients to be managed.
Right, institutionalized.
Exactly. Everyday Lives says, no, a person with a disability shouldn't live a service life surrounded only by paid staff and clinics. They should have a life that looks like yours or mine.
In the community.
In the community. Actually involved, not just physically present.
But the implication of this new contract and the whole reason for this deep dive is that the system wasn't delivering that everyday life effectively.
It was struggling. And the source material is surprisingly candid about why. The system was hitting a wall regarding sustainability.
Let's look at the data from the fall of 2024 that's cited in the guide. It paints a pretty stark picture.
It really does. At that time, there were over 11,000 individuals on waiting lists for home and community-based services.
11,000.
Just pause on that number. That's 11,000 people who have been approved for help, who need support, but are waiting for the resources to actually arrive.
So that's the demand side. But the supply side, the workforce, that was also cracking.
Right. You had a 9.5% vacancy rate for supports coordinators. Nearly 1 in 10 desks at these agencies was empty.
Wow.
And for direct support professionals, the people doing the hands-on daily care, like helping with meals or hygiene, the vacancy rate was 14%.
So you have a classic pincer movement, rising demand, shrinking workforce.
And to compound it, you have rising acuity. The people on that waiting list and in the system have increasingly complex needs. We're talking about dual diagnoses, complex medical fragility. The old administrative structure just wasn't built to handle that level of complexity efficiently.
So the house was on fire. Now, the timeline suggests this isn't a standalone fix. This looks like phase 2 of a broader strategy.
It is. ODP already rolled out similar performance-based changes for residential services, like group homes, back in January 2025. Now, starting January 2026, they're applying this model to the supports coordinators,
Lining up the incentives.
aligning the incentives across the whole board so everyone is rowing in the same direction.
So let's get into the solution. The guide outlines 4 focus areas or, pillars to stabilize the arch.
Right. Sustainability, workforce, clinical capacity, and responsiveness.
Let's tackle sustainability first. I feel like in government documents, sustainability is often a euphemism for budget cuts. Is that the play here?
It's actually more about resource reallocation. The guide pushes hard against the traditional model of licensed community homes.
Those are the 247 staffed group homes.
Yes, they are incredibly expensive and labor-intensive. If you have a workforce shortage, relying on a model that requires 3 shifts of staff per day plus backups, it's a math problem that doesn't solve.
So where are they shifting the focus?
Toward life-sharing and supported living. Think of life-sharing somewhat like foster care for adults, but with more agency. An individual lives with a host family or a designated person in a private home.
Which presumably offers a more natural everyday life feel than a facility.
Exactly, it's more integrated. And yes, it is more cost-effective. The argument is that if we move people who can thrive in life-sharing out of the expensive 247 homes, we free up resources to tackle that 11,000-person waiting list.
It's about using the right tool for the job.
Right.
Okay, moving to pillar 2, workforce. We mentioned that 9.5% vacancy rate. How does a contract change stop people from quitting?
This is where the bureaucracy was actually the villain. Under the old system, SE is billed in 15-minute units.
Oh, I can see the headache there. You spend 12 minutes on a call, do you round up? Do you spend 5 minutes documenting the 12-minute?
Precisely. It turns a social service job into a data entry job. It causes massive administrative burnout because you are constantly watching the clock.
Justifying your existence in quarter-hour increments.
I sent an email, that's 1 unit. I drove to the house, that's 2 units. It's exhausting.
So what's the fix?
The new model shifts to a monthly case rate.
Explain that.
The organization gets paid a set amount to manage the person's care for the month, period. It decouples the funding from the stopwatch.
Yeah.
It frees the SC to focus on the person. If someone needs 10 hours of help one week and 2 hours the next, the SC can just do it without worrying about whether they build enough units on the quiet week.
That sounds liberating, but it also creates a risk, doesn't it? If I get paid the same whether I talk to you once or 10 times, couldn't I just
do less?
Yeah.
That's where the performance part of performance-based contracting comes in, which we'll get to. But on the workforce side, they've also introduced a new role, the Associate Supports Coordinator.
How does that differ from the standard SC?
It's a smart triage move. Previously, only fully qualified SCs could do most tasks. The associate role allows a different tier of employee to handle specific logistics, like facilitating life course planning tools or handling administrative hurdles.
It reminds me of the medical world utilizing nurse practitioners or physician assistants to take the load off the surgeons.
It's the exact same logic.
Oh, yeah.
Let the primary SC focus on the high-acuity, complex crisis management, and let the associate handle the planning frameworks and paperwork.
It spreads the load.
Spreads the load, creates a career ladder, and hopefully helps with retention.
Which leads us perfectly to Pillar 3, clinical capacity. You mentioned the rising complexity of cases. How does the guide address the medical reality?
This is one of the most critical sections and, frankly, one of the most sobering. The guide explicitly mandates a focus on the fatal 5.
The fatal 5. It sounds like a movie title, but I assume these are the leading causes of mortality.
Yes. These are the 5 preventable conditions that most often lead to death or serious illness in this population. Choking, seizures, sepsis, dehydration, and constipation.
I think most listeners would expect seizures or sepsis, but constipation, that seems, well, manageable.
For you or me, yes. But for someone who is nonverbal, who perhaps has low muscle tone or is on medications that slow the digestive system down, a bowel obstruction can be lethal.
Wow.
And if they can't communicate the pain until it's too late, it becomes a crisis. The new contract requires SEs to be trained to spot these specific risks. It shifts the role from just social coordination to clinical vigilance.
So they aren't doctors, but they need to be the early warning system.
Exactly. They need to know that if a person is acting out behaviorally, it might not be behavior. It might be a toothache or dehydration or pain they can't express.
And adjacent to that is trauma-informed care.
Huge emphasis here. The data shows a disproportionate amount of trauma in this population. History of restraint, abuse, loss of agency.
Right.
The new standards require staff to understand that history. You can't just barge in with a plan. You have to understand why a person might react negatively to authority or changes in routine.
Okay, so that's clinical. Pillar 4 is responsiveness.
This is the feedback loop. It measures speed, how fast are referrals handled, how smooth is the discharge. But importantly, it leans on family engagement and satisfaction surveys.
Just so the customer experience finally counts.
It has to. If the families aren't happy, the data will reflect that. And in a performance-based model, bad data has financial consequences.
Let's transition to the mechanics of this deep dive. How does this actually roll out? Because you can't just flip a switch on January 1st and expect every agency to suddenly be trauma-informed and clinically sharp.
No, and ODP recognizes that. The guide outlines a phase-in approach. It's a 3-year ramp-up starting January 2026.
So year 1 is a grace period.
Sort of. Year 1, which is January 2026 to June 2027, is about building capacity and establishing a baseline.
Okay.
The state is saying, we know you aren't perfect yet. Show us where you are and show us your plan. They want to see that the SEOs are setting up the structures to track this data.
And year 2?
Year 2 is beat your own score. You have to show improvement against the baseline you set in year 1. It's continuous improvement.
And year 3 is the hammer.
Year 3 is where you have to meet statewide benchmarks. If you aren't hitting the standard by then, you are failing the contract.
The guide uses employment as a specific example of how this tracking works. This is the Competitive Integrated Employment, or CIE.
The stats here are fascinating and honestly a bit depressing. Currently, the statewide rate for people with IDA having a regular paying job is only 18%.
18%.
Yeah. But when you survey adults with disabilities, 40% say they want a job.
That represents a massive failure of the system to connect desire with opportunity.
Exactly. So the new standard forces SEOs to measure that gap. They can't just check a box saying we asked about a job. They have to track the delta between wants a job and has a job and actively work to close it.
So if you have 100 people who want jobs and only 10 have them, you need a plan to fix that.
Right.
There's also a section on technology first. This feels like another buzzword potential. Are we just giving everyone iPads and calling it progress?
It's deeper than that. It's about independence versus intrusion. Think about it. If you need support overnight, the old model was to pay a staff member to sleep in your house.
Right.
That's expensive and, frankly, intrusive. It's hard to have an everyday life with a stranger in your living room.
So what's the alternative?
Remote monitoring, smart sensors, medication dispensers. The mandate is to look at tech first. If a sensor can keep someone safe and allow them to be alone in their own home, that is preferred over paid staffing. It's dignity through technology.
Let's talk about the engine that drives all of this. Money. We mentioned the monthly case rate, but are all months created equal?
No. They've tiered it. There is standard targeted support for folks with less intense needs and intensive TSM for those on waivers or with high complexity.
So the payment reflects the difficulty of the case, not just the time spent.
Yes.
But I can imagine the anxiety of a small, nonprofit provider. They're used to billing for every 15 minutes. They know how to budget that. Suddenly that stops. What if they miscalculate? What if they go broke during the transition?
That is a very real fear. The guide addresses it with stabilization payments. Essentially, if an organization's revenue drops by more than 3% during the transition, purely because of the new formula, the state will top them up.
So there is a safety net.
For a limited time, yes. It gives them breathing room to adjust their business model. But the real driver is the carrot. This is the pay for performance, or P4P.
I love a good acronym. How does P4P work in practice?
It's incentive pay. If an SKO hits specific high-quality targets, like high rates of community integration or excellent person-centered planning fidelity, they get bonus payments.
Nice.
It's the state putting its money where its mouth is. We will pay a premium for excellence.
Ideally, that creates a race to the top. But, and here comes my cynicism, who checks the work? In these systems, there's always a danger of juking the stats. Who ensures the data is real?
There are two main layers of accountability. First, there's the ISAC, the Information Sharing and Advisory Committee. They are the high-level stakeholders reviewing the trends. But the second one is the game changer for the average family, the public directory.
This sounds like the Yelp concept you alluded to earlier.
It is. ODP is going to publish a directory of SKOs that includes their performance data. It will even list any corrective actions they're under.
That is radical transparency for a government agency. Usually that stuff is buried in a PDF somewhere deep on a website.
Right. If you're a parent looking for an agency for your child, you won't have to rely on word of mouth or a nice brochure. You can look at the directory and see who is actually meeting the employment benchmarks, who is responding quickly to referrals, and who isn't. It empowers the consumer to make an informed choice.
And competition usually forces quality improvements. If you're the worst-rated agency in the county, you either fix it or you lose clients.
That's the theory. Market pressure applied to social services.
I want to address a practical concern. If I'm a listener and my brother has a supports coordinator he really trusts, does January 1st, 2026 mean he gets assigned someone new because of this contract shuffle?
The guide is very explicit about this. Continuity of care is the priority. The goal is that individuals keep their current SKOs.
Okay, good.
This is a back-end change. How the agency gets paid, how they're measured, what training they take. For the user, the face across the table shouldn't change. The experience should just feel better, more responsive.
So no disruption, just improvement. That's the promise.
That is the promise.
As we wrap this up, I'm thinking back to that keystone analogy. It feels like we are reinforcing that stone so the arch can hold more weight.
I think that's accurate. For a long time, social services have been trapped in a transactional mindset.
Yeah.
We acted like care was a commodity you could measure in minutes, like pumping gas.
I gave you 15 minutes of support. Here's the bill.
Exactly. But care isn't a commodity. It's a relationship. This shift to measuring outcomes is significant because it acknowledges complexity. It balances the technical side, the billing, the data, the clinical fatal five with the deeply human side. Trauma-informed care, the desire for a job, the need for a real life.
It's asking the system to care about what the person cares about, not just what the auditors care about.
Precisely.
Here is a final thought I want to leave you with today. We've been zooming in on disability services in Pennsylvania, but zoom out. Think about this model, performance-based contracting, moving from paying for inputs tests run, hours logged, to paying for outcomes, health achieved, jobs found.
It's a model with wide applications.
If we can successfully pull this off here, imagine applying that lens to the rest of healthcare. Imagine applying it to education. If we stop asking how much did we do and start asking did it work, how might that fundamentally change the way we take care of each other as a society?
It changes the whole conversation.
It really does. Thanks for helping us navigate the deep dive today.
Thank you.